Good evening to one and all. I am Dr. Ajita Misra on behalf of IAP India Digital Team. Welcome you all for the webinar. I'll request all our viewers to kindly like and subscribe our YouTube India channel, that is IAP India channel, for more updates on our upcoming webinars. And today's webinar is being organized by IAP Women's Cell Telangana State. And the topic for the webinar is Buteyko Techniques. I would request Dr. Vivi Manjula ma'am to kindly take over and start.
Thank you, ma'am. On behalf of IAPWC Telangana Women's Cell Team, I'm Joint Coordinator Dr. Vivi Manjula Kumari. I would like to invite Dr. Ajita Misra ma'am on behalf of my team. And my team is led by Dr. Hana Rajshekhar ma'am as State Coordinator. Myself, Dr. Vivi Manjula Kumari, I'm Joint Coordinator. Himabindu ma'am is one of the sub-coordinators. Maunima Bila ma'am and Himani Pradar are the other sub-coordinators of our team. On behalf of our team, we welcome you, ma'am. Dr. Ajita Misra, ma'am, she will be speaking on Buteyko Techniques to address ailments caused by dysfunctional breathing. This is the topic for today, and ma'am is a certified Buteyko method instructor. She also did her FBPI and MPT in cardiopulmonary. Ma'am is dealing with other breathing techniques which are very much helpful for asthmatic patients and all. Before that, I would request Dr. Hana Rajshekhar ma'am to speak a few words about our current webinar. Over to you, Dr. Hana ma'am. Ma'am, we can't hear you, ma'am. Unmute yourself, ma'am.
Yeah.
Yes.
Good afternoon, one and all. Thank you, Manjula, for the nice, welcome that you have given each one of us and introducing our team. And I am really actually happy to give the greetings for Dr. Ajita Misra because we are quite closely connected with her. She, in fact, taught my students, and she was a great fan of all the students. They used to like her classes. For the clarity with which he explains each and every topic and her friendly nature. And he doesn't mind patiently explaining things which was well appreciated by both faculty and students. This, webinar is going to be a great learning process for everybody. I wish you, Dr. Ajita Misra, all the best.
Thank you, ma'am. Thank you so much, Hana ma'am.
Thank you, ma'am.
Dr. Ajita Misra, ma'am. Shall we start the webinar?
Sure.
Yes, ma'am. Over to you, ma'am. Thank you.
First of all, thank you very much, IAP, for giving me this platform. Thank you very much, Anna ma'am, for giving me this opportunity. Manjula ma'am, thank you for that wonderful introduction. And I actually want some of my family members to listen to it. Probably I'll get a relaxation from cleaning the rooms and mopping the floor once they realize that I can do something more than that. Yeah. Anyways, so, and thank you very much, all the participants, for actually, taking that risk of listening to me for 1.5 hours. It's going to be almost 1.5 hours by the time I can wind up all this. So thank you very much for being here, for sparing your valuable time for this webinar. And now,
before Dr. Ajita goes in, hello, Dr. Ajita.
Yes, ma'am.
Dr. Manjula, I'd just like to interrupt. I think Dr. Maunima is prepared to introduce Dr. Ajita officially.
Okay, ma'am.
Yeah.
Dr. Maunima, ma'am. I would request Dr. Maunima, ma'am, to introduce our current speaker, today's speaker.
Thank you, Dr.
Welcome, ma'am.
On behalf of TS IAPWC, I welcome our speaker for today, Dr. Ajita ma'am, onto the platform. Ma'am is a qualified cardiopulmonary physiotherapist from Sai Institute of Paramedical and Allied Sciences, Jefferdon. And she's also a certified Buteyko practitioner, trainer, and breath worker. Apart from Buteyko practitioner, she also has a rich academic experience of working spanning from 2006 till date at various academic institutions like Army Hospital at Delhi, Career Institute of Medical Sciences, and Rajiv Gandhi College of Physiotherapy, Sai Institute of Paramedical Sciences, and Jayoti Vidyapith Women's University, Sumandip Vidyapith University, and currently ma'am is working as a guest professor at Apollo College of Physiotherapy at Hyderabad. Ma'am, we are really glad to have you on our platform today. I hope it's going to be a very enriching learning session for all the participants on platform. Thank you so much, ma'am.
Thank you, Dr. Monima. I have got another good, introduction. Again, I can, maybe if you can be kind enough to just record it and send it to me so that there are people who needs to listen to this.
Ma'am, it's on YouTube all the while. You can check it anytime, whenever you're free.
I need to tell my family to just, switch on YouTube and listen to this. Okay, so thank you very much. And I'm really honored being on this platform, speaking for IAPWC Telangana. And thank you, Hannah ma'am, once again for giving me this opportunity. Now, I know that most of the participants here are more interested in listening about Buteyko rather than dysfunctional breathing. I'm pretty sure of it. But then until and unless we understand what is dysfunctional breathing, we will not be able to understand what is Buteyko and why are we learning about Buteyko. So I'll start with a small presentation. 2 or 3 main points. One is whenever you have a question, because I have too many slides and covering them up in a short duration is going to be a challenge. So whenever you have a question regarding any of these slides, please type it down in the chat box. So at the end, it will be easy for me to take up questions in a sequence. The other thing is that since I'm so used to classroom teaching, there might be occasions when I might ask you that whether I'm like audible or is the slide visible or are you getting the point. Please, at least some of you unmute yourself and give a response so that I know that you're there with me. So said that, I'll just start sharing my screen. Okay. All right. So our today's topic is Buteyko technique to address ailments caused by dysfunctional breathing. Before we start this, let me ask everybody a question. Now, this is a very silly question, but still it is important for this webinar. The first question is, what is your mouth meant for? What is your mouth, M-O-U-T-H, mouth meant for? Anybody can answer this question or, okay, now if you put it in the chat window, I won't be able to see it. So anyone can unmute yourself and answer the question. Anybody from the participants. What is your mouth meant for? No one? Are you still there with me? Am I audible?
Yes, ma'am. Yes, ma'am.
Okay. Thank you, Manjula ma'am. So what is your mouth meant for? It's a simple question. What do you use your mouth for? When we were kids, we were taught, like, eyes are meant for seeing and ears are meant for listening. So what is your mouth meant for?
Talking and eating.
Talking and eating. What is your nose meant for?
Smell, breathing.
Okay. Now, so please, throughout the topic, throughout the webinar, we'll all remember these two things. Our mouth is for eating and speaking. Our nose is meant for smelling and breathing. So you cannot eat and you cannot talk through your nose. So we are not going to breathe through our mouth. Okay. So Buteyko breathing is all about nasal breathing. So whenever we go to a practical session or whenever I say that we inhale through the nose and we exhale through the nose, or we are inhaling or we are exhaling, automatically by default that inhalation and exhalation is through nose and not through your mouth. We are not going to do any kind of mouth breathing during this session. And since we'll have a practical session at the end, so please make sure you're not breathing through your mouth. Okay. Now, the topics that we are going to discuss during this webinar are what is dysfunctional breathing, hyperventilation, effects of hyperventilation on your systems, on different systems of the body, and what is Buteyko technique. And when I'll teach you about what is Buteyko technique, we'll have a small practical session. I'll run through these slides so that we get more time for practical. Breathing. Breathing, according to me, corresponds to taking charge of one's own life. Lucy Eriguet, sorry, she's French. All right, so mechanism of breathing. Inhalation begins with contraction of the diaphragm. Everybody knows that there is a central tendon. The diaphragm is over it. The central tendon contracts. The diaphragm goes down. It flattens. Now the abdominal pressure increases. The pressure inside the thoracic cavity, pleural cavity decreases. It drops. There is negative pressure. When there is negative pressure in the pleural thoracic cavity, the air gets sucked in. Negative pressure respiration. Now, normally the diaphragmatic excursion is 3 to 5 centimeters, but it can be increased in well-conditioned people like athletes. It can be 7 to 8 centimeters. Exhalation is the movement of air out of the bronchial tubes through the airways to the external environment during breathing. Now, what we need to understand in this slide is that exhalation is a passive process. Until and unless you go for a forced expiratory technique, you're blowing something or you're blowing air, or you forcefully try to clear your nasal passage. Until and unless you are trying to do this, exhalation is going to be passive. So the diaphragm recoils back to its position, the lung recoils back, and the air is pushed out of the lungs. So this is your exhalation. This is a very clear image of inspiration and the position of diaphragm during inspiration and expiration. The first image shows you a relatively flat diaphragm when the lungs are full of air. So the person is in inspiration. The person inhales and holds the breath, and an image is taken. So this is the first inspiratory technique, inspiratory image. The other one is image after exhalation. So you can see the diaphragmatic dome over here. It has come back to its resting position. So this is the amount of diaphragmatic excursion that takes place when you breathe in and out. Now, the important thing, why are we studying about this? Any kind of deep breathing exercise is not just breathing deep. Breathing deep means the air goes to the remotest areas of the lung. But that does not happen. When you ask a person to take a deep breath, it is usually a big breath. The person is not taking the air to the remotest part of the lungs. He or she is actually taking a bigger breath. So if you ask a person to take a deep breath, the tidal volume will increase. So deeper breath have higher tidal volumes and require a greater drop in the intrapleural pressure. It is very simple, like a vacuum cleaner. You switch on the vacuum cleaner at power 1, the suction is a little less amount of air goes in. You increase the suctioning power, you increase the negative pressure, more amount of air is suctioned in. So if the intrapleural pressure drops -1, a certain amount of air goes in. If you can drop it down to -2, this is just an example. If you can drop it down to -2, the amount of air that is sucked in will be more. So a deeper breath, a bigger, higher tidal volume requires this intrapleural pressure to drop down to more than what it usually goes down. Okay, now check your breathing. All of you can do this. You can actually check your breathing. There is a thing called as respiratory wave. You might have seen my template, the one that I've used for making this PowerPoint. There's a wave. So I like waves. So respiratory wave consists of 3 sections. The first one is abdominal sector. The abdominal sector is the movement between your diaphragm and your abdomen. So the diaphragm descends down into the abdominal cavity. This is the abdominal sector. When this happens, the abdominal pressure is increasing. And because of this positive or increased abdominal pressure, your abdomen moves anteriorly. It moves out. Okay? It bulges out. Now, abdominal sector is responsible for almost 60% of the total breathing efficiency. So now all the participants who are listening to this, try breathing with one hand on your chest and one hand on your abdomen and see what happens when you breathe in. How much movement do you feel on the abdominal sector? of your respiratory wave. So just try placing one hand on the abdomen, other on the chest, and breathe in a normal breath through the nose. No mouth breathing. Okay, so breathe in through your nose, breathe out through your nose, a normal breath in, a normal breath out, and see how much movement you can feel on your abdominal sector. The next is the thoracic sector. Now, thoracic sector is the sector between the diaphragm and the lower 6 ribs. Okay, so the diaphragm, the lower 6 ribs, and posteriorly it goes to the 5th thoracic spine. So the movement will be between the diaphragm, the lower 6 ribs, and on the posterior aspect at the 5th thoracic vertebra. Now, to check this, all you have to do is place both the hands at the lower ribs. You're all physiotherapists, you know it how to do it. You know how to do this. So just place both the hands at the lower 6 ribs and feel that 30% of respiratory wave. And the last is the subclavicular sector. Subclavicular sector is this, just below the just below the clavicle. So this is your last 10%. So the wave goes from the abdominal sector. So the first, when you breathe in, first the abdominal sector bulges out. 60% of total breathing efficiency depends on this. So 60% of the breathing work of breathing is done. Then the lower 6 ribs expand. They move outward and a little upward. So this is the thoracic expansion. If you see it posteriorly, this movement will also be felt at the level of 5th thoracic vertebra. And then comes the third sector, that is subclavicular sector. Subclavicular sector is responsible only for the 10% of your breath work. Now this 10%, we usually call it as apical breathing. So apical breathing is this, the upper chest, that's all. So from 5th thoracic vertebra to the cervical at the posterior aspect, and at the interior aspect, it is the subclavicular region, the region just below your clavicle. This is 10% of your subclavicular sector. So the breathing wave goes from abdomen to lower thorax, from lower thorax to subclavicular sector. Now, why I say check your breath, because there are many people, if randomly you just go to a person and you say, in your family also, you can check this in your family. If you randomly go and tell a person that, okay, breathe, and you watch them breathing, you watch the movement of all these 3 sectors, you will realize that many people, when they breathe in, instead of the abdomen coming out, it goes in. It is more like they are clicking a picture. So when you're clicking a picture, you draw a breath in and you suck your abdomen in. So it's like, and then you click a picture. So that Ganesh ji wala abdomen, the bulged out abdomen does not come in the picture. The picture should be smart, it should be good. So you suck in air and at the same time you suck in your abdomen. Many people breathe that way. When they breathe in, instead of coming out, the abdomen goes in. Check it randomly in as many people as you can, and you will definitely find a few people who do this. Okay, now adequate diaphragmatic engagement is enough to provide 75% of thoracic space change when breathing is quiet. Now, you might have seen that some people, when they breathe, not only them, the person sitting 1 foot away or maybe 1 feet away, 2 feet away can see them breathing. Most of us breathe that way, that when you're breathing, people around you can see you breathing. Quiet breathing is something which is rhythmic, light, calm, slow, and the most important thing, it is invisible. So even when you're not making any efforts, you're not deep breathing, you are not manipulating your breath in any way, if you have a normal healthy breathing habit, the diaphragmatic engagement is enough to take care of 75% of your breathing. The only thing is that your way of breathing and your respiratory wave should be correct. So if check your breathing, the respiratory wave is correct, then you don't have to do any kind of deep breathing. A quiet breathing, sitting at one place, invisible, slow, rhythmic breath will take care, the diaphragm will take care of 75% of your breathing. Now, this diagram, though it's big and explaining the entire diagram will take a few minutes, what I want you to notice in this diagram is the amount of partial pressure of oxygen and partial pressure of carbon dioxide that is exhaled out of your lungs. You can see it here, right side top. The partial pressure of oxygen in in exhaled air is 120 mmHg, and the partial pressure of carbon dioxide in exhaled air is 27 mmHg. You are exhaling much more oxygen as compared to carbon dioxide. Now, some books will say that it is not 27, it is near about 30. Why I'm asking you to remember this particular value is, imagine when you take in carbon dioxide, it is just 0.3 mmHg. When it reaches the lungs and it mixes up with the rest of the carbon dioxide that is already present in the lungs, it goes up, it increases to 40 mmHg. And when you're trying to exhale it out through, I always use this word expire, sorry for that. So when you're trying to exhale it out, only 27 mmHg of carbon dioxide is exhaled out. There is a very tiny difference between the amount of carbon dioxide which is present in your system and the amount of carbon dioxide that you are exhaling out. Whereas for oxygen, it is vice versa. The oxygen, just a second. Okay. So the oxygen, the partial pressure of oxygen that you're going to exhale out or that comes back to the lungs is 104. When it goes out, it is almost 120 mmHg. So there is a little oxygen present in the air, which is there in the lungs. It mixes up with the deoxygenated, I'll repeat it again. The air the blood which goes into the pulmonary system from the deoxygenated blood that goes to the lung has certain amount of oxygen in it and a large amount of carbon dioxide in it. The air that you breathe has got a lot of oxygen in it and a little bit of carbon dioxide in it. So when this deoxygenated blood goes to the pulmonary circulation, there is gas exchange. The air that you're expiring out is partial pressure oxygen 120 mmHg and partial pressure carbon dioxide 27 mmHg. Very small difference between what has come in and what is going out. Dysfunctional breathing, how do we define it? Only those who know how to breathe will survive. Pandit Acharya ji said this. Dysfunctional breathing may affect up to 1 in 10 people. So congratulations. Every one person among 10 of us suffer from dysfunctional breathing. And even in that, females and people with asthma are at the top of the list. So women and people with asthma will have higher incidence of dysfunctional breathing. Now, what is dysfunctional breathing? The definition, the traditional definition of dysfunctional breathing is an umbrella which consists of any kind of altered breathing pattern where the normal biomechanics has changed. Now, biomechanics is the movement of the chest, the movement of the abdomen, the movement of the thorax in all, the spinal movement while you breathe in and out. So dysfunctional breathing here is, the definition consists of only the biomechanical pattern of breathing has altered, and it has altered so much that the person has intermittent, time and again getting symptoms, or chronic symptoms of dysfunctional breathing. Now, these symptoms can either be respiratory symptoms such as shortness of breath, commonest thing, rapid breathing, difficulty breathing, chest tightness. So they can either be respiratory or they can be non-respiratory. Now we'll come to non-respiratory. Before that, okay. My definition of dysfunctional breathing is a little different. I, along with biomechanics, would like to consider biochemistry and baroreceptors also when I talk about dysfunctional breathing. So biomechanics, movement of the thorax, abdomen, diaphragmatic excursion. Biochemistry is gas exchange, the partial pressure of oxygen and carbon dioxide that we just saw, and the blood pH. The gas levels, the partial pressure of carbon dioxide and oxygen in the blood maintains the pH of the blood. And hence, in all, because blood is like at every nook and corner of your body, so it actually manages the pH of your body. And the next is baroreceptors. how baroreceptor sensitivity acts in this, we'll study about it. So baroreflex sensitivity, vagal nerve stimulation. Usually in Buteyko, we say that our breathing is a three-legged stool. Now these three legs are biomechanics, biochemistry, and the baroreceptor, or the psychophysiological aspect. If any one leg is deranged, it's not working properly, it's broken, the stool cannot stand. So if one part of your breathing, one aspect of your breathing is not working well, it will affect the entire body, and it will also affect the other two legs of the stool, that is the biochemistry and the baroreflex sensitivity. Now dysfunctional breathing can be classified into thoracic dominant breathing. Thoracic dominant breathing is forget about the abdominal sector. So forget about 60%. Only remember the 30 and the 10%. So total 40%. So thoracic dominant breathing is you are not using your abdominal sector. The other is thoraco-abdominal asynchrony. There are people who suffer from this thing called as thoraco-abdominal asynchrony. That is, the thoracic movement and the abdominal movement while taking a breath in and out are not synchronized enough. Even before the thorax can start expanding, the diaphragm goes back into its original position. It recoils. So your thorax do not get time to completely expand. Or vice versa. As I said, that most of the people, when they breathe in, instead of their diaphragm going down and the abdomen coming out, their abdomen goes in. They generate negative pressure inside their abdomen also, instead of generating negative pressure only in the thorax. So this is thoraco-abdominal asynchrony. Movement of the abdomen interiorly is normal. Movement of the abdomen inside, sucking in of your abdomen while breathing in, comes under the category of thoraco-abdominal asynchrony. Then there is hyperventilation. This is the most thing we are going to talk about this in the rest of the webinar. PVFMD is PVFMD is paradoxical vocal fold movement disorder. We are not going to study about it, but you should know about it. The reason being, your vocal fold has an opening. When you breathe in, the air, that opening should open up. I mean, that passage should open up, and your vocal fold should open, and the air should pass easily into the lungs. Okay. In some people, there is paradoxical vocal fold movement. Paradoxical is when you breathe in, the folds close. So you get symptoms like asthma. But then PVFMD is not treated by physiotherapists. There it is treated by speech therapist. So whenever you take up a patient with dysfunctional breathing and you want to treat that patient, make sure the patient does not suffer from PVFMD. And for that, the patient needs to go to an ENT and to a speech therapist. So this is not our field of work. We'll be skipping this. Thoracic dominant breathing, we'll touch it in the rest of the webinar. I'm not going to elaborate it. The main thing we are going to talk about is hyperventilation. Okay. Now what is functional breathing? There is an old definition of functional breathing and there is a new definition of functional breathing. But functional breathing is breathing affects your respiratory, cardiovascular, neurological, gastrointestinal, muscular, psychic system, and also has a general effect on your sleep, memory, ability to concentrate, and your energy levels. I love this lady, Donna Farhi. She has actually summarized the entire functional breathing in this one quote. Okay, functional breathing is something that changes according to your body's requirement. You want to run, your respiratory rate should increase, your heart rate should increase. The blood flow to the periphery, to your legs, your muscles should increase. It does. You just had your lunch or dinner, the body needs to digest the food. Again, there has to be a change. The blood has to go to the digestive system, more to the digestive system as compared to your brain and to your periphery. You feel sleepy, you feel drowsy. There is less blood anywhere else as compared to your belly. So this is functional breathing. Your breathing changes with the requirement of your body. Now, a person's breathing to be functional must adapt appropriately to changes in their external environment and their internal metabolic and emotional conditions. Now, breathing's functionality can again be divided into three: biomechanical efficiency, biochemical efficiency, and psychophysiological efficiency. We'll study all of them in parts. Now, before we go to the next slide, biomechanical efficiency can be maintained only if you can maintain your diaphragmatic excursion. That is, if the person activates the diaphragm and uses it efficiently. Diaphragmatic excursion should be 3 to 5 centimeters minimum. And if a person is well conditioned, it can go to 7 to 8 centimeters as well. Biomechanical efficiency also means that many of you might be musculoskeletal physiotherapists also in this list of participants. Have you ever thought about it that a person coming to you with neck pain, pain in the upper trapezius, trigger points in the upper trapezius, or back pain can actually have dysfunctional breathing, and because of that dysfunctional breathing they're suffering from these aches and pains? If not, next time check. The reason being, the diaphragm gets attached to the xiphisternum, the lower 6 ribs, and L1 to almost L3 lumbar spine. So a major part of your diaphragm is attached to your spine, and the diaphragm at the posterior aspect is thicker than the diaphragm at the interior aspect. The interior attachment and the interior lining of the diaphragm is less as compared to the posterior. Now, what happens is, if the diaphragmatic excursion reduces, it will not only affect the posture of the patient, it will also affect the functioning of all the other muscles of the back. So, musculoskeletal pain can be generated through a diaphragmatic uh, dysfunction or reduced function of the diaphragm. And it can also be vice versa, that a person is having back pain, and so the person is unable to work up his or her diaphragm properly. So a back pain or muscle tightness, stiffness can lead to lesser excursion of the diaphragm as well. So it can go both ways. Now, biochemical efficiency is how well your breathing is able to maintain the normal PO2 levels and PCO2 levels in your body. How well your breathing is able to manage the uh, pH of your blood. So that is the biochemical efficiency. And psychophysiological efficacy is about the baroreflex sensitivity. You might have heard of sympathetic nervous system and parasympathetic nervous system. Sympathetic nervous system gives you a fight or flight reaction. It puts you in that fight or flight reaction. It sympathizes with every damn thing in your body. And you require sympathetic nervous system when you're in stress to sympathize with you. In today's world, most of us are always in stress. We are always running behind something. And so most of the time, our brain perceives this entire situation as fight or flight reflex. It calls for a fight or flight reflex. Our brain feels that, okay, the person is in stress, the sympathetic nervous system should be activated. Earlier, when we used to live in caves and hunt for our food, this fight and flight reaction was good. It was nice. It was required to survive in the wild. But now we do not need it so much. Of course, a little bit of stress in a day, maybe work related or personal stresses or anything, COVID related stress is fine. Once in a day, a little bit of 5 minutes of stressed up, panicked, okay, no issues. But when you stay in this state continuously, the parasympathetic nervous system overrides your the sympathetic nervous system overrides your parasympathetic nervous system. So your brain tries to keep your sympathetic nervous system always more active as compared to the parasympathetic nervous system. Now, why is this bad? Your parasympathetic nervous system is actually responsible for relaxing the body, for relaxing the mind. It is more like, you know, uh, digest and sorry, rest and digest. I usually forget this. So rest and digest. So you take rest and you digest and you sleep, you relax, your body stays calm, your mind stays calm. So it helps in actually relieving any kind of anxiety, panic disorders, and even depression. But to activate that parasympathetic nervous system, you need an effective breathing mechanism. Now, how you can activate your parasympathetic nervous system by your breathing, we'll come to that. When we'll read about Buteyko, you'll understand. So, psychophysiological efficiency is again how well your breathing can adjust itself to your psychological state of mind, and how can it bring your body to a homeostatic state. Now, homeostasis is bringing any system of your body to its balanced state, whether it is biochemical efficiency mein, the body has to come back to the original normal pH of 7.4. The partial pressure of carbon dioxide should be 40 mmHg. This is the homeostasis when it comes to biochemical efficiency. When it comes to psychophysiological efficiency, you cry for a while if you're sad, you are happy, you jump for a while, you are worried about something, you are stressed for a while, it's okay. For a while, everything is fine. But then you need to come back to your normal state. If your body is unable to do that, if you're unable to get out of that anxiety or panic disorder, the breathing functionality of psychophysiological aspect, it is not efficient. The breathing is not efficient to bring back homeostasis to the psychophysiological state of your body. Okay. Now, as I said that, covering all the dysfunctional breathing pattern would be very, very difficult. The time is too short for that. So what we'll do is we'll come to hyperventilation, because this is the commonest form of dysfunctional breathing. Now, most of you know what hyperventilation is. You're breathing too much air, like overeating. So you're over breathing. If you overeat, you know what can happen. You can become obese, you can suffer from diabetes, hypercholesteremia, and you can die of heart disease. There are multiple things. But do you know what happens when you hyperventilate? Apart from the fact that when you're hyperventilating, you're taking in too much air. So what else can happen? Hyperventilation is defined as breathing in excess of current metabolic need. You require 100 ml of oxygen. To get that 100 ml of oxygen, instead of breathing 500 ml of tidal volume, you're breathing 700 ml of tidal volume. That doesn't make sense. If you can get your 100 ml of oxygen from 500 ml of tidal volume, why do you need to breathe 700 ml of tidal volume? You can just go with that minimum 500 ml of tidal volume. But we don't do that. We breathe extra, and we like breathing more. Deep breaths, suck in air as much as you can. Please don't suck in air. Okay, episodes of acute hyperventilation are usually brief. Have you seen a small kid crying? When they cry, they try to suck in air. This is how they cry. So they're actually sucking in air. When you're speaking continuously, you literally eat air. It is called as aerophagy. Right now I'm speaking. So because I'm speaking, I cannot have a normal respiration through my nose. So what I'm doing is I'm breathing in a lot of air through my mouth. While speaking, I'm eating air. Aerophagy. I'm literally sucking in air. So I'm hyperventilating. Anybody who's in the field of teaching or who's in a field where they need to speak a lot, hyperventilate. But then acute hyperventilation is something where you hyperventilate for a short duration and then you go back to your normal respiratory rate and normal respiratory depth. Emotional shock can cause this, panic attacks can cause this, but acute hyperventilation is reversible. However, symptoms of hyperventilation can also develop to a lesser degree from chronic hyperventilation. Now, chronic hyperventilation is, there are people who will work for a while. Maybe they'll just go clean the kitchen, platform, table, something. And I can only talk about cleaning right now. You know, working from home is all about cleaning. So they'll just clean something, they'll sit down and they'll do this. This is hyperventilation. You yawn a lot, you sigh a lot, you gasp a lot, you breathe a lot through your open mouth. This is all hyperventilation. And knowingly or unknowingly, we all hyperventilate. The thing is that some people can come back to their normal respiratory rates and normal tidal volume after hyperventilating for a while. Some people get into this habit of hyperventilating every single day. They hyperventilate every now and then without even realizing that they're taking in too much air. So this is hyperventilation. Now, hyperventilation, what does it do? Oxygen, forget about oxygen. We are not going to talk about oxygen. I'm a bigger fan of carbon dioxide. So we'll talk more about carbon dioxide. So when you hyperventilate, you take in large amount of air and then you exhale a lot of air out. As you remember, the exhaled air has got 27 mmHg of PCO2. The partial pressure of carbon dioxide is just 27 mmHg. Now try and understand that if you breathe a little extra, this exhaled air will have a partial pressure of carbon dioxide, say 35 or 37 mmHg. So you're exhaling out a little carbon dioxide, extra carbon dioxide with every breath. And when you do this, you develop a condition called as hypocapnia. And it is absolutely easy to develop this condition called as hypocapnia. You just have to exhale a little extra. You might have seen so many videos showing you for COVID recovery. They show you that breathe in and then blow the candles. Done. One hyperventilation. You have exhaled a little extra carbon dioxide. Then they tell you, okay, now start blowing the balloon. Each time you blow into that balloon, you're again exhaling extra carbon dioxide. You already have a very little margin, 27 to 30, 35. That's all. That is the only margin you have. So you exhale a little extra carbon dioxide. Then they tell you that take a paper and then start blowing it. Take a hanky, blow. So the more you blow air, with every blow, you exhale out extra carbon dioxide from your body. And if the amount of CO2 in the end expiratory air or the end expiratory breath is more than, say, 30, 35, you will develop hypocapnia. Hypocapnia is a condition where there is reduced carbon dioxide, reduced partial pressure of carbon dioxide in your blood. And the effects of hypocapnia, we have always learned that, carbon dioxide is a waste gas. Oxygen is what is important. So if you eliminate more of carbon dioxide, you'll get more of oxygen. It's not like that. In fact, it's vice versa. If you exhale out too much of carbon dioxide from your body, you're not going to get any oxygen. It is like a barter system. When the blood reaches the tissue needs to give carbon dioxide to the blood. And in exchange of that, the tissue gets oxygen from the blood. If you do not have sufficient amount of carbon dioxide to provide to the provide to the blood is not going to dissociate from oxygen. Somebody is saying something. Should I stop? Dr. Manjula, someone is saying something.
No, ma'am, not exactly.
Okay. So hypocapnia is a condition which can lead to three very important things. And it is really, really necessary that we understand it now. First thing, it will reduce the extraction of oxygen from the blood. So the oxyhemoglobin curve or oxyhemoglobin dissociation will reduce. If you do not have carbon dioxide, the blood is not going to dissociate itself from oxygen. So even if your blood has got 100% oxygen in it, your tissue is not getting any oxygen until unless you give carbon dioxide to the blood. So hypocapnia can reduce the oxygen delivery to the tissues. Carbon dioxide has this special quality. It relaxes smooth muscles. So when carbon dioxide is present in good amount in your body, 40 mmHg in your body, it helps in keeping the smooth muscle around the bronchus relaxed. It helps in keeping the smooth muscle in the medium sized vessels. You all know medium sized vessels have smooth muscles in them because they're responsible for blood pressure management, for regulation of blood pressure. So the smooth muscle in the medium sized vessels, the smooth muscle in the bronchus, they will constrict if there is lack of carbon dioxide in your body. If you have hypocapnia, the bronchus, the smooth muscle around the bronchus is going to constrict. Imagine if the smooth muscle around the bronchus constricts, what will happen? No matter how much you try to breathe in, how strongly you breathe in, that air is not reaching the lungs because the bronchus is constricted. Again, imagine that somehow you breathe in and the lung gets sufficient amount of air, and the oxygen and carbon dioxide exchange, everything is done. Now this blood with good amount of oxygen reaches the tissues, but because you have already exhaled out so much of carbon dioxide, your tissues do not have carbon dioxide to give to the blood. So the blood will say, I'm not giving you any oxygen, I'm going. Simple. You don't have carbon dioxide, I'm not giving you oxygen. So even though the blood has got oxygen in it, the saturation is good, it is not going to deliver that oxygen. So hypocapnia has a number of bad effects on your body. Carbon dioxide is a really, really important gas. It is not a waste gas. So effects of hypocapnia, the pH body will become, the pH will go to alkalinity and you'll develop respiratory alkalosis. The cellular effect will be movement of chloride from intracellular to extracellular environment, decrease in cellular bicarbonate, hypophosphatemia. Now, explaining all of it is out of the scope of this webinar, but definitely we can discuss it sometime in future. This is what I've told you right now is the gist of this. Okay, this is the Bohr's effect. Increased affinity of hemoglobin for oxygen, decreased desaturation of hemoglobin. So if there is hypocapnia, the hemoglobin is going to hold on to oxygen. It is not going to leave it. So decreased desaturation of hemoglobin. Tissue hypoxia. Tissue hypoxia because the blood is not giving you any oxygen. Metabolic effects, inhibition of aerobic glycolysis. Again, when you do not have oxygen, there is no aerobic glycolysis. Increased pyruvate production, inhibition of pyruvate oxidation, accumulation of lactic acid. You will gas out very soon. Gas out very soon means that you go out for a jog or for a walk, and within 5 minutes, you start breathing through your mouth. You open your mouth, you sit down, you try to catch your breath, you're gassed out. Your legs are paining badly because there is a lot of lactic acid accumulation in them because of the anaerobic activity. All this just because you do not have sufficient carbon dioxide in your body. This has got nothing to do with the oxygen levels of your blood. In the lungs, hypocapnia can contribute to bronchoconstriction, decrease lung compliance, lung damage. Imagine a person, now again, I'm coming to the COVID because many of us are treating COVID cases. So imagine a person who is already dealing with viral pneumonia. Viral pneumonia is always interstitial pneumonia. Viral pneumonia is always interstitial pneumonia. Now, the first sign of interstitial pneumonia is reduced contractility and expandability of the lung tissue. It is damaging the interstitium. And then you are further pushing the patient towards hypocapnia by asking the patient to blow out through the mouth. So when the patient who is already dealing with viral pneumonia goes into hypocapnia, it will result into further lung damage and decreased lung compliance. There is already decreased lung compliance because of the interstitial pneumonia. It will go further down the drain if you keep telling the patient to blow out. Blood pressure, myocardial contractility, cardiac blood flow, everything is going to be adversely affected. Cardiac output, stroke volume fall in response to hypocapnia, alkalosis. So the cardiac output, stroke volume, both will reduce. Coronary artery spasm, Again, it's a response to hyperventilation. So just imagine just a little extra carbon dioxide that you're trying to breathe out is leading to all of this. Now, the majority of people, just 1 minute of determined overbreathing. 1 minute of determined overbreathing is like you have an Apple phone or you have a MacBook and you were just going somewhere, holding it in your hand, and it drops and it breaks into pieces. It's gone. And you know the reaction, how what is going to happen if you just drop, or maybe you dropped your Apple mobile phone in a bucket of warm water, bubble bath. So imagine. So that will give you approximately 5 minutes of determined overbreathing. But here we are just considering 1 minute of determined overbreathing. So this overbreathing, it will be like, and then there will be a pause, and then there will be, what will happen next? So this is overbreathing. Now you're overbreathing. So what will happen? Reduces cutaneous peripheral blood circulation. You'll have cold hands. And if your mom and dad had paid for it, you'll also have a paler skin. Interferes with peripheral nerve conduction. You'll have tingling sensation in the hands, lips, everywhere. The entire body will be tingling. Apple phone, MacBook on the floor in the bubble bath, and mom, dad paid for it just few days back. Lowers muscle contraction threshold. Stimulates cerebral vasoconstriction. So vision, hearing, sensory perception, balance, orientation, judgment, cognition, everything goes for a toss. Just 1 minute of overbreathing. Now, carbon dioxide is not a waste gas. I have already told you, we have already covered all the points which are there on this slide. So I'll move ahead with this. Okay. This is a very small representation of what happens when you have reduced PCO2 in TOR. That is in blood in the system. So alkaline, if it goes to 7.8, death, 7.7, coma, of course, 7.6. Now the normal value is 40 mmHg. Anything reduced, alkalinity, anything more than this, acidic. So you can see the effects of alkaline or acidic pH of your blood on the system of the body. Now this is cerebral circulation drop. I have, I won't say I stole it. I actually borrowed it from a research. I like that word, borrow, instead of steal. So, okay, I borrowed it from one of the researchers. Cerebral circulation drops 2% for every 1 mm drop in CO2. So just imagine 1 millimeter drop in CO2 in carbon dioxide will lead to 2% reduced cerebral circulation. Here's the graph. You can compare both of them. Okay, finally we have come to Buteyko breathing. Just let me check the time. Okay, we still have time, right? So the Buteyko method is primarily a system of breathing training. I'm not going to read this slide. I'm going to just tell you what Buteyko breathing is. Buteyko breathing was developed by Dr. Konstantin Buteyko, and he was a Ukrainian physician. Now, what happened was he himself suffered from hypertension, and he started studying people who were critically ill and were on their deathbed. So what he tried to find out was whether their underlying condition because of which they were dying, like a person has cancer or a person has tuberculosis. Back then, even tuberculosis was fatal. So a person dying is on the deathbed and the respiratory rate is high. The person is suffering from hyperventilation. So is the hyperventilation because of the underlying cause, or is the underlying cause getting worse because of hyperventilation? So he just tried to find out that, and he did extensive research on it, and tried to find out the cause which was leading to the death of these critically ill patient, or bringing them closer to their last breath. He just tried to figure out what was it. It was their breathing, or it was their underlying organic disease. So he claimed that his program of breathing retraining, which aims to, just a second, which aims to raise carbon dioxide, could purportedly benefit up to 150 diseases. I haven't found all the 158, though I'm a certified practitioner, but I've found many. Diabetes, hypertension, asthma, COPD, in children, craniofacial development, dental cavities, and deviated nasal septum, operated, post-operated deviated nasal septums, and sexual intimacy, issues with sexual intimacy, then PMS in females, and of course, the breathing in females is different from males. So even that has a very long article on it. I mean, we have a long list of conditions that females suffer from during their PMS and how they can be controlled by altering their breathing. So this, okay, this is really interesting. See, I'll show you what it is. Okay. Now, the respiratory rate of the body, when I say body, it's the human being. We are considering you as a whole. So the respiratory rate is 20. The tidal volume is 300 ml. Why 300 ml? Because at the respiratory rate of 20, you're breathing so fast that you cannot take anything more than 300 ml. When you're breathing fast, the diaphragm and the muscles don't get time to, move properly. The diaphragm will not go down completely because you're not giving it enough time. So if your respiratory rate is 20, your tidal volume is going to reduce from 500 to 300. The total minute ventilation will be 6 liters. But now if you check the alveolar ventilation at the same respiratory rate, what will happen is the respiratory rate, this is at the level of alveoli, the respiratory rate is still 20, the tidal volume is still 300, but 150 ml of air is wasted in the dead space. Now here we are talking about the anatomical dead space because the physiological dead space will be different for different people. So anatomical dead space for everybody is more or less 150. So here 150 ml of the total 300 tidal volume goes in that dead space. So what actually goes to the alveoli or what actually reaches the alveoli is just 3 liters. Again, now if you reduce this respiratory rate from 20 to 12, so the respiratory rate is 12, tidal volume will definitely increase. If you're taking 12 breaths per minute, the diaphragm has time to go down and increase a good amount of negative pressure. So the tidal volume will be 500 ml. Again, the minute ventilation is same, 6 liters. Alveoli, at the level of alveoli, 12, 500 minus 150, 4.2 liter, much better than 3 liters. But if your respiratory rate comes down to 6 breaths per minute, you will be surprised to know that no matter how many books tell you that respiratory rate is fine, between 12 to 15 is normal or 15 to 16 is normal, the optimum respiratory rate is 6 breaths per minute. So if it is 6 breaths per minute, the total tidal volume is going to be 1006 liters. Minus 150, 5.1 liter of air is going to reach the alveoli. So this is definitely far better than 4.2 and 3 liters. But 3 liters is worse. If you can bring it to 4.2, it is still fine. It is good, not really bad. So this was about, okay. Now the 3 basic tenets of Buteyko breathing or Buteyko technique appear to be encouraging nasal breathing. As I said, mouth is not meant for breathing. If you try breathing through your mouth, you can as well try eating through your nose. Just try it. Please don't try it. Hospital staff already have other things to deal with. Okay. So second is slowing the respiratory rate. As I said, most of us breathe for like 15 to 20 breaths per minute. Even that is too much. You need to reduce it. 12 breaths is fine. If you can bring it down to 10, better. Having a respiratory rate of 6 is a little difficult because, we are not hermits. We are not sage. We are not into meditation, sitting at one place and meditating at our basal metabolic rate. So that cannot happen. We need to move. We need to think, work. So a respiratory rate of 6 is definitely not possible for us, but definitely a respiratory rate of 10 to 12 is possible for us. Okay, slowing the respiratory rate. And the last is possibly resetting arterial PCO2 levels at a higher level. Okay, through breath holding. Now we'll come to what is breath holding. Now these are the basic principles of Buteyko breathing. Control pause, we'll do it now. Reduced breathing, slow breathing, switch to nasal breathing, mindful breathing, and breathing control to influence autonomic nervous system. Okay, this will deal. Now I'm going to stop sharing the screen, and I would request the participants to switch on their cameras so that we can have a practical session. Because I mean, if you're comfortable doing that, because I cannot see you, and if I cannot see you, I cannot correct you if you're breathing, if you're not exactly breathing the way I'm asking you to. So I'll just pause the sharing. Okay. All right. Oh my God. Okay. So if the participants would like to switch on their cameras, they may, so that I can at least see whether you're breathing right. Okay. So now the control pause is a test developed by Buteyko, Konstantin Buteyko, and it is a very simple test to actually understand the tolerance of your body towards carbon dioxide. So what we are going to do is we are going to raise the carbon dioxide level of our body a little bit, and we are going to see at what point the brain reacts to that carbon dioxide level. Now, how will brain react to the carbon dioxide level? Once the carbon dioxide level starts increasing, the brain is going to signal the respiratory centers to breathe, to start breathing. So this is the reaction of your brain to increase carbon dioxide level. Now, if your brain's tolerance is towards carbon dioxide is good, you can increase the carbon dioxide level to a greater extent. If your body has reset your brain's carbon dioxide tolerance to a lower level, because what happens is when you constantly hyperventilate and you constantly stay in a position of hypocapnia, your brain perceives that this hypocapnic state is the normal state. Simple. So if the body is in a state of reduced carbon dioxide for a very long duration, it is going to set its level of normal carbon dioxide to that particular level. Like for example, it is 40 mmHg, but for a very long duration you have been exhaling out a lot of carbon dioxide. So now the normal carbon dioxide level of your body is say 35. So the brain is going to understand or is going to perceive 35 mmHg as the normal carbon dioxide content of the body. If the carbon dioxide goes from 35 to 36, it will give you a signal to breathe again. Okay. So now in order to check control pause, you'll need your mobile phone. Switch on the stopwatch and sit comfortably, sit straight, so that you have enough space for your diaphragm to go down and your ribs have enough space to expand. So just sit comfortably but upright. Breathe in through your nose, breathe out through your nose. Now this is a normal breath in and a normal breath out. And then you need to hold your breath. So I'll breathe in and I'll breathe out and I'll hold my breath. The moment you hold your breath, you need to switch on the stopwatch. And then the first definite desire to breathe. Okay. First definite desire to breathe. The moment you feel that you need to breathe in, you will immediately release your nose and you'll breathe in. You will not use your willpower to keep holding the breath. Now, this definite desire to breathe can come in or can kick in say 10 seconds, 5 seconds, 20 seconds, whatever is your tolerance level. So what you need to do is hold your breath, and as soon as you feel the first desire to breathe, or you feel there is some kind of involuntary contraction of the muscle in your chest or in your abdomen, or you feel like swallowing, this is an indication that you have to breathe. Okay, so just check for how many seconds you can hold your breath. Now, for a normal, healthy individual, this breath holding can go up to 60 seconds. For a person with good breathing, no dysfunctional breathing, 40, even 30 is fine. Anything below 10 is definite dysfunctional breathing. If you have a control pause of more than say 20, 25, you still have scope to increase it. So what you need to do is check your control pause, write it down, say if it is say 10 or 11 seconds. Now the next what you'll do is you'll try reducing your breathing. So for reducing your breathing, there are many ways. One, single nostril breathing. You breathe in. Now Buteyko has a number of exercises. These are the basic ones. So reduced breathing. Reduced breathing is you breathe through one nostril. It's not alom vilom, so you're not going to exchange the nostrils. Just breathe through one nostril. Okay, for say 5 minutes. So what you're doing is you are actually reducing your tidal volume half, 50%. So this is one. Second is sit straight, breathe in and out, but try to take a very short breath. So just a short breath in, a short breath out. A breath just to fill your nostrils. So 1 centimeter of breath in, 1 centimeter of breath out. If you feel that you need to breathe more, 1 inch of breath in and 1 inch of breath out, not more than that. So this is another way of consciously reducing your breathing. The other way is simple. You just cup your hands, place them on your face, covering your nose and your mouth, and you breathe into your hand. So you're breathing from the hand and then breathing out into your hands, into your palms. So what you're doing is you're concentrating carbon dioxide in your hands and you're breathing in the same air which you had just expired out, which you have just exhaled out. So the small gaps between the finger will give you some amount of fresh air, but rest you're breathing from the hands and you're breathing out into the hands. So this is another way of reducing your breathing. Now, one more way of reducing your breathing is try doing box breathing. So in box breathing, you breathe in for a count of 4, you hold it for a count of 4, and then you release your breath for a count of 4. This is again reduced breathing. Now, if you try doing this 4, 4, and 4, it is like 4 plus 4 is 8, and then 4 is 12. So one breath is 12 for a count of 12. So automatically your respiratory rate per minute is going to reduce. So this is another way of reducing your breath. Now, if we go for a exercise where we increase or where we give small doses of carbon dioxide to our body, we call it as steps exercise, or we call it as breath holding with steps. Why do we do it? You might have heard of Wish Kanyas. They were not born like that. They were given small amounts of poison slowly, and to a point where they became immune to it. They will not die of it, and that poison is not going to harm them in any way. So what we are going to do is we are going to give small amounts of carbon dioxide to our body to reset the to reset the normal tolerance of our brain to carbon dioxide. So right now your brain is sensitive to a carbon dioxide level of say 30. Slowly we give it bouts of carbon dioxide so that this amount, this 30 mmHg, increases to 40 mmHg. If you give it once, like if you try to bring this from 30 mmHg to 40 mmHg in one go, what will happen is your brain will tell you, okay, this is too much of carbon dioxide, let's breathe, and your respiratory rate will increase. So we don't want that. We don't want to go into dysfunctional breathing. We do not want to go into a type of breathing where you're breathing like 20, 25 per minute. So what we'll do is we'll do short breath holds. So you take a normal breath in, a normal breath out. You hold your breath for 3 seconds or for a count of 3. You release your release this hand, you release your nose, you breathe in again. For say 5 to 10 seconds, you breathe normally. Again, after 5 to 10 seconds, you again hold your breath. You take up normal breath in, normal breath out, and hold your breath for 3 seconds. So this is like giving small amounts of carbon dioxide to your body. What you can do is, just to check the efficacy of Buteyko breathing, check your control pause, do this short breath hold exercise for 5 minutes, rest for 5 minutes, and then again check your control pause. And it will definitely be increased. Even if it is increased by 1 or 2 seconds, it will be increased. So this is how you, so this is how you check your control pause, and then you check how Buteyko breathing is going to help you. Psychophysiological aspect of breathing, usually when you breathe slowly inhale through the nose, slowly exhale through the nose. And there is a study done in Taiwan that if your inspiration and expiration is equal, the ratio is equal, 5:5. You breathe in for a count of 5, you breathe out for a count of 5. So if they're equal, the chances of activating your parasympathetic nervous system, activating your vagal tone, and inducing relaxation, dealing or treating anxiety is, I mean, it can be done just by keeping the ratio, keeping the respiration slow and equal amount of inspiration and expiration. So next time when you feel anxious, instead of doing this, just breathe in slowly for 5 seconds, breathe out slowly for 5 seconds. Equal ratio and slow breathing is enough to tap into your parasympathetic nervous system and to activate the vagal tone. Okay, so this is about psychophysiological steps exercise I've done. Yeah, there is another very good exercise that you can use for yourself every day in the morning. When you get up, just check one of your nostrils will be blocked, and if you are a mouth breather, you do not breathe through your nose during the night, you might have disturbed sleep, snoring, and you will wake up with a dry mouth. So if you wake up with a dry mouth and a blocked nose, you're definitely breathing through your mouth during sleep. So what you need to do is first switch to nasal breathing instead of mouth breathing. And switching to nasal breathing is very simple. You just have to mindfully uh, breathe during the day, to keep in mind that you're not opening your mouth for breathing. Or you can use a 3 mm micropore tape. I don't have mine over here. So it's just a simple micropore tape. Tape your mouth for say half an hour, 1 hour in a day. So that will help you in switching from mouth breathing to nasal breathing. One. Second, in the morning, if your nose is blocked and your mouth is dry, there is a very simple way of opening your nasal passage so that you don't breathe through your mouth. Breathe in, breathe out. Hold your breath for as long as you can. Use your willpower as long as you can. And then release it. Do it once, wait for 30 to 60 seconds, repeat it. Without any other medications, without any other efforts, this will open up your nasal passage. Of course, if your nasal passage has got any polyps or gross nasal septum deviation, this will not help. So it will not help you with the structural thing, but it will definitely help you if you're just breathing through your mouth and that is why your nasal passage is blocked. Now, how it opens up the nasal passages, there is this nitric oxide in the sinuses. Everybody's talked about it, let me know about it. So this nitric oxide gets accumulated when you're holding your breath. So one thing is the nasal, when you block your respiration, you hold your breath, the carbon dioxide increases. When the carbon dioxide increases, the smooth muscles relax, and this nitric oxide, which is accumulated in your nose, when you release the nose and you breathe in, it helps in opening up your nasal passage. It also helps in proper delivery and distribution of the air that you're breathing in. So this is the hypothesis. It hasn't been proved yet, but then this method works, that is proved. So this is a simple nose decongestion exercise. A child of 5 years can be taught this exercise. No Buteyko exercises are taught to children below 5 years of age. Now, I think I have already exceeded my time. Manjula ma'am, should we go to the question sessions, or because it's 3:45.
I think better to go through question sessions, Ajita.
Yes, ma'am, I'll do that.
Yeah.
Okay, only chat will work.
Questions are all, no questions, ma'am.
Okay.
We asked them to type in the chat box, but nobody typed it. No
FB and
questions here and there.
Instagram.
Yeah.
Manjula.
Yes, ma'am.
Manjula, there is a question.
Ma'am.
Yeah, just check the chat box. There are some questions.
Ma'am, is it that you breathe in, breathe out, and then hold direct, or after deep
Or
breath?
after deep breath.
Cheryl, no. You breathe in a normal breath in, a normal breath out, and then you hold your breath. And if you can hold your breath for 3 seconds, release it. Wait for 5 to 10 seconds, again hold it. You keep doing this for 1 to 2 minutes, you will realize that there is excessive salivation in your mouth, which is a sign of increased parasympathetic activity. So you can try that. And yes, you hold the breath after breathing out. Any other questions?
No, ma'am.
Okay.
Uh,
For which condition it is beneficial? Buteyko was primarily developed for asthma and hyperventilation, of course, but now Buteyko treats a large variety of conditions in children, craniofacial development, because when children are accustomed to breathe through their mouth, what happens is their lower jawline recedes, it goes back. As a result, the teeth or the upper jawline protrudes out, and we feel that, okay, this is protruding out, so we need to put braces. So then we go to a dentist, we put braces. Now, children who mouth breathe also suffer from a lot of dental cavities, dental hygiene, because your mouth is open to all kinds of pathogens. So dental hygiene is a problem in children who breathe with open mouth. Enlarged adenoids can be seen in children who breathe through their mouth, and the size of their airway reduces as the airway develops. The size of the airway reduces if they are chronic mouth breathers. So such kind of children will have they will not have a clear jawline. They will face concentration issues in their school. They won't be alert during the day because they won't be able to sleep well during night. So yes, that is in children. Then sleep apnea, snoring, insomnia, anxiety, panic, hypertension, diabetes, and intimacy, sexual intimacy issues in people, PMS in females. The list is pretty long, but yeah, Buteyko helps all in all these conditions. Okay. I lost track. Okay. I think Ajit Kumar, I have answered your question. Do we have nod? Do we have to nod our head? Saw a video. That is just a distraction. You can do that. That is for nasal decongestion exercise. You hold your breath and either you do this or you just sway your body. Why we teach this is that it is a kind of distraction which helps you in holding the breath for a longer duration. You can do it if you want to. Usually in children it is fun. You ask them, like my 5-year-old son, if I just ask him to hold his breath and sit, probably he'll just open his nose in a while. But then if I ask him to sway or nod or just move around, it's easy to hold the breath. So yes, you can do that. It's just a distraction technique. It has nothing to got with it doesn't have anything to do with this nasal decongestion. Is asthma patients can be used in acute exacerbation? If you teach asthmatic patient Buteyko, they can actually avoid acute exacerbations. During acute exacerbations, if they already know Buteyko, they will practice it, and the exacerbation can be controlled. But yes, you'll have to teach them these exercises before this acute exacerbation. You cannot expect them that once they are like doing this and you tell them, okay, don't do this, hold your breath, they're not going to do it. So yes, you can treat asthma, and the patient himself or herself will use it once they feel acute exacerbation. Do we have to nod our head or sway body side to side during Buteyko breathing? Came across a video. I have already answered this question. You can do it. It is just a distraction. It is not really a part of the exercise, but yes, you can do it. Good afternoon, ma'am. How can we use Buteyko in COVID rehabilitation? COVID rehabilitation, a good question. See, we need to wear a mask. Everyone knows that. Now, if you wear a mask, you feel that breathing through that mask while wearing the mask, it's difficult to breathe in, and most of the people find it difficult. So, what we do is we open our mouth for breathing. There are many people who do this. Remember, your first line of defense against COVID is nasal breathing. Your nasal nitric oxide, the mucosa of your nose, the fine hair like structure in the nose, has the ability to not only humidify and filter air, it can also kill a number of pathogens, bacteria, fungi, viruses. So, your first line of defense against COVID is nasal breathing. Stop breathing through your mouth, and half of the problem will be solved. Next, if you're using a mask, make it a point that inside the mask you do not breathe through your mouth. Opening up the mouth is like it's an open invitation. You're sucking in large amounts of air, and mask is not going to help you if you breathe through your mouth open inside the mask. Anyhow, that the mask that we're wearing, the cloth mask that we wear, it does not gives us 100% protection against any kind of virus or bacteria. It has its limitations. So on top of that, if you start breathing through open mouth, again, you're more prone to this you're more prone to infection as well as to this fungal infection, because your mask is wet, humidified. If you don't wash it properly and then you open your mouth, you breathe through your mouth, just imagine what's going to happen. Second, COVID rehabilitation, as I said, that stop breathing through mouth. Interstitial, treat COVID pneumonia as interstitial lung disease. The patient does not require excessive or vigorous lung strengthening exercises. They don't need it. What they really need is to work up their diaphragm well, to activate their diaphragm, and to help them take in air, a normal amount of air in, and to exhale it out properly. Now, when you inhale and exhale through your nose, instead of opening your mouth, your blood or your body extracts oxygen both during inhalation as well as exhalation. There is a reason that your nostrils are not as big as your mouth. This is a sign. See, nostrils, when you breathe through the nose, the nostrils produce a certain amount of resistance to air. The air doesn't like, try breathing like this. There is no resistance to air. You can take in as much air as you want. But when you're breathing through your nose, you cannot do like, you cannot take this much of air at once. There is certain amount of resistance that the nostrils, the size of the nostrils provide, or there is a resistance to the air that is going in. That resistance is for a purpose. The air goes in slowly, and when you exhale, the air comes out slowly. So there is this oxygen and gas exchange both during inspiration as well as expiration. There is this John Hopkins rehabilitation, 3-phase rehabilitation for COVID rehabilitation, for COVID recovery. So I have put all the 3 phases, all the exercises in a video form, and I've put it on my YouTube channel. For COVID rehabilitation, please go check John Hopkins. You don't want to check my video, that is fine. You can just type John Hopkins rehabilitation program for COVID recovery, and you will get the 3-phase rehabilitation program. And no rehabilitation program says that you need to make the patient blow through their mouth. Please don't do that. There is a research, I don't know whether I have time to share it with you or not, but there is a research which says that there were 3-4 people, not in our country, somewhere else, and these 3-4 people, they were suffering from some symptoms of COVID, like shortness of breath and fatigue, like standing in front of the wash basin, brushing their teeth, even that would make them fatigued. So they were COVID positive, and they got themselves again tested. The COVID report was negative, but it seems like they were suffering from long COVID. We have all heard of it, long COVID. So they tried going to different doctors, and finally they were all collected at one place, and the hospital authorities called a breath worker. So the breath worker the first thing she did was she asked a CABG for all three of, sorry, arterial gut gas and blood gas analysis for all three of those patients, ABG. And it was surprising that all those 3-4 patients with long COVID had reduced carbon dioxide levels. Their partial pressure of carbon dioxide was reduced. And once they were treated for that reduced carbon dioxide levels, their symptoms got better. So just imagine, by excessive expiration or excessive exhalation through mouth, probably we are pushing all the COVID patients towards long COVID. Maybe this is what we are doing. These patients are not supposed to suffer. And then what we say is that they have just fought a viral infection, so their body is weak. Probably it's not their body which is weak. It is probably just the PCO2 levels that are low. So yes, Buteyko directly, no. But yes, COVID rehabilitation can be done by John Hopkins rehabilitation. You can check it on my YouTube channel. Ajita Misra, you'll get it. Okay. Does this breathing fit for COPD condition or any particular type of breathing, ma'am? COPD condition, if it is hyperventilatory condition, yes, it does. See, Manju ma'am, what happens is when you are checking a person's breathing or any case, COPD, asthma, anything, there are certain parameters on which a breathing is tested. One of them is respiratory rate, the other is tidal volume, minute ventilation, then the muscles that are involved in respiration. Your respiratory muscle tightness can lead to reduced diaphragmatic excursion. Reduced diaphragmatic excursion can lead to muscular tightness in people. So there are a lot of things. COPD patients, you'll usually find that they use their accessory muscles to breathe. So go for a diaphragmatic activation technique and teach them how to retain air in the lungs, breathe in and breathe out through their nose rather than breathing through their mouth, because asthmatic patients, they have this habit of breathing out through pursed lip. For a short duration, it is fine breathing out through pursed lip, but then there is again an article, I can't pull it up right now. So even pursed lip has its own side effects. So anybody who thinks that breathing exercises are simple and they can be prescribed to anyone safely, mind you, breathing exercises have more side effects than as compared to any other exercise in physiotherapy. So yes, COPD condition, Buteyko can definitely help, but then you need to understand what is wrong with the patient. That requires a good amount of assessment. Assess for the respiratory muscle tightness, check the diaphragmatic excursion. Usually for if an asthmatic patient or a patient with COPD comes to me and I feel the patient is hyperventilating, I'll ask the patient to go and get an ultrasonography done, USG done of the thorax. And I will ask the radiologist to tell me exactly what amount of diaphragmatic excursion is happening. So that is what I'm going to do. So then from there I'll catch up. From there I'll check his control pause and I'll deal accordingly. I'll prescribe exercises accordingly. If the diaphragm is not moving well, I'll first go for diaphragmatic activation and then I'll go for CO2. Okay, can it be given for acute disorders in ICU patients, ma'am, who is cooperative and able? uh, Ajit Kumar ji, again I would say the same thing. You can use Buteyko breathing for anybody, even ICU patients. But Buteyko breathing is used for patients in whom you suspect hyperventilation, in whom you suspect that the CO2 levels are low. Now, again, one breathing exercise is not like, it is not like one shoe fits all. So you need to see, when you talk about ICU patients, there are a lot of things. PNF techniques for respiratory muscle, facilitation techniques for the diaphragm, and now they have this proning for diaphragm. There are a lot of things, lots of things, and the box breathing can be done, coherent breathing can be done. So ICU patients, if you talk about a particular condition, probably I'll be able to answer better. But I mean, ICU patients can be, there's a long list. You're talking about pediatric ICU, you're talking about geriatric ICU, neuro ICU, cardiorespiratory ICU, which ICU? Of course, I don't know. I mean, ICU is a very, very vague term. So if you can narrow it down a little, probably I'll be able to answer it better. Can you explain in brief what's happening during that breath hold at end of expiration? I mean physiology. Okay. When you hold your breath, you increase the carbon dioxide level of your blood. The body, the entire body, the carbon dioxide level increases. Now, at the end of this breath hold, at end of expiration, Acha, okay, at the end of expiration, you are holding the breath. Fine. So, if you breathe in, you have air inside, and then you hold the breath. The exchange of gases from the air, which is already there in your lungs. You breathe in, you have air, you have fresh air in the lungs, and then you hold the breath. That won't increase the carbon dioxide level as much as when you have exhaled out the entire air. You have fresh air inside the lung and then you hold the breath. The gas exchange is going on, so the carbon dioxide level might increase, but not as much as it will when you exhale out completely and then you hold the breath, because now you do not have fresh air in the lungs. So there is no way the body is going to get some extra oxygen. So you will be able to increase your carbon dioxide levels in a very short duration. So you just exhale out, there is no fresh air in the lungs, and you hold the breath. So that will quickly increase the carbon dioxide level and you'll get a response. If you are checking your control pause, your brain will immediately give you a signal, okay, now this is too much of carbon dioxide, you need to breathe. And if you're performing an exercise, you're giving small bouts. So even that small bout of carbon dioxide will help. So that is the reason we hold it after exhalation and not with the breath in. Dr. Sai, I hope I have answered your question. Okay, is Buteyko in and out will show better cardiac patients? I'm sorry, I did not get your question, Vanam. Is Buteyko in and out will show better cardiac patients? Do you need? Are you trying to ask me that will Buteyko exercises help cardiac patients? If that is the case, then let me tell you one thing. Strong breath holds are contraindicated for cardiac patients. So nose blocking, unblocking exercise should not be done by patients. Thank you for asking this question. Should not be done by cardiac patients who have some severe, serious cardiac illnesses. They should not do this breath holding, strong breath holds. Small breath holds they can do. 3 seconds, they can do it. But strong breath holds are contraindicated in cardiac patients, in pregnancy. That's it. So cardiac patients, I don't know, hypertension, of course, Buteyko helps in reducing blood pressure. It can help patients with hypertension, high BP. Cardiac patients, you need to narrow down it. Cardiac patients can be anything: cardiomyopathy, CABG, myocardial infarction, coronary artery disease, hypertension, so valve disorders. Okay. Do we have to stick to 3 seconds hold or till we have air hunger or desire to breathe? Okay, Cheryl, these are different exercises. The one which you did in which we hold the breath and we keep holding it for as long as we can, that is for nasal decongestion. This is strong air hunger. Strong air hunger is you want to breathe and the hunger is really strong. You want a lot of air, but still you're trying to hold on. You're using your willpower. So this is only for nasal decongestion. Now in Buteyko, we have different levels of air hunger: light, moderate, strong. So depending upon the case, depending upon the condition, the assessment that we take, we decide what kind of exercise, what amount of air hunger we can prescribe to a particular patient. Now 3 seconds hold is basically a recovery breath. We call it as recovery breath. It can be done in sitting as well as walking. For example, you climb stairs and you're breathless. So what do? You just do the you do this. Instead of doing that, next time when you climb stairs or you have walked for a while or you have done something heavy and you're out of breath, instead of opening your mouth and breathing in, Just try to hold your breath for 3 seconds, release, breathe normally for 5 seconds, again hold your breath for 3 seconds, release, breathe normally for 5 seconds. Do this, you'll be able to bring your respiratory rate, your heart rate, everything under control in a very, very short time. So that is recovery breath that I just taught you. Basically, Buteyko is huge. Bringing in all the exercises in one webinar is just not possible. And here we are talking only about hyperventilation. There are other things as well, as I said, sleep disorders, craniofacial development, hypertension, diabetes, on and on and on. So vagal nerve stimulation, anxiety, panic, depression. Okay, so ma'am, pursed lip breathing helps when breathless. So is it considered in mouth breathing? Yes, pursed lip breathing is mouth breathing, but there is a difference. See, there will be, just pick up any 3 random people and try teaching them pursed lip breathing. They will all have their own version of pursed lip breathing. Some will do this. Some will do this. Others. So everyone will have a different way, a different version of doing pursed lip breathing. So first of all, learning pursed lip breathing correctly yourself, teaching pursed lip breathing correctly to your patient, and making sure that the patient uses pursed lip breathing only when it is required. Pursed lip breathing, if you go on Google and try searching who developed pursed lip breathing, you will not get an answer, because it wasn't developed by anybody. It was developed by asthmatic patients who found it difficult to exhale out because their airways were collapsing. So what they did was they started exhaling out through their mouth, which made them feel better, because then there was a back pressure. So the airways were open, they were not collapsing. Now we give pursed lip breathing to everybody without even realizing whether that person really requires pursed lip breathing or not. If the person's airways are not collapsing, why do you need to give pursed lip breathing to a patient? The patient can breathe normally through nose, and even nasal passage, breathing in and out through nasal passage, even that creates a back pressure. So you don't require pursed lip breathing until and unless you feel that the patient is unable to exhale out of his nose. So pursed lip breathing has its own side effects. And yes, it is mouth breathing. So be very careful whom do you prescribe pursed lip breathing. Okay, any studies in neurological patients? There are studies in neurological patients. Again, neurological patients, what particular condition we are talking about when it comes to neurological patients? I mean, what particular uh, disease or injury, or what are we talking about? So that
CP and
really
stroke.
matters.
They're asking in particular about the CP and stroke.
Okay, CP and stroke. No, there are no such studies in CP and stroke. One thing that can help stroke patients, again, stroke patients, no, I don't think so. No, CP and stroke, no. Sorry. Cardiovascular conditions, ma'am. Cardiovascular conditions. Let me think. No. Directly, Buteyko cannot help you with cardiovascular conditions. Ma'am, it's 4 p.m. Please wind up. Oh, yes. Okay, so I've got orders to wind up. Any more? And what is your experience about Buteyko helping for nasal septum? I have patients, Cheryl, whom I've treated for nasal septum deviation, and not just without surgery, even post surgery. So any patient who has nasal septum deviation, if it is not gross and if it does not require surgery, can be treated with Buteyko, and they get very good results. Some patients who get surgery for the correction of deviated nasal septum should also be treated with Buteyko, because if they don't stop breathing through their mouth, the nasal surgery is going to be a failure. And most of the patient who get surgery done for deviated nasal septum say that the surgery was a failure because the symptoms are still there. So yes, we can treat nasal septum deviation. Okay, I need to wind up. Manjula ma'am is here.
Thank you so much, ma'am. Thank you so much for your
You're welcome.
lecture.
Manjula ma'am, sorry to interrupt. We have a lot of questions pending on YouTube.
Yes,
so can we just rush through them?
Yes, ma'am.
A
Certainly.
quick rush.
Yes, ma'am. Yes, ma'am.
I expect Ajita ma'am to give short answers so that we can wind up in a
Yeah,
due
I'll
time.
try doing that, ma'am. That's one of my... how do I see the questions?
I'm reading them.
Okay.
Just one second. What are the benefits of this technique, and what is the perfect time to practice this technique?
I'm sorry, ma'am. Can you please repeat it once?
Yes, ma'am. Yes, ma'am. Shraddha is asking, what is the perfect time to practice this technique, and what are the benefits of this particular technique?
Buteyko breathing is depending upon patient to patient. We give 6 to 7 sets or sessions of Buteyko breathing, and it can be done according to the patient's convenience. Buteyko breathing is usually practiced with every single breath that you take in the day. So, benefits of this technique. I have already told you so many benefits of these techniques. Okay. Helps in sleeping better, craniofacial development, again, bringing down your BP, decongestion of the nose. I don't know. I mean, I've already gone through the list of conditions which can be benefited by Buteyko breathing. And at what time it should be done? 6 sessions in a day. You can pace it out according to you. That is depends from patient to patient. We give an exercise prescription. So
another question, ma'am. Dr. Prachi Patil is asking, is inhaling and holding allowed?
Inhaling and holding will make no sense until unless you're doing box breathing. But then box breathing is used for certain conditions, not for all. So
Preeti M is asking, can this technique be used in nasal sinus, ma'am?
yes, of course, you can get rid of sinusitis, rhinitis, and congested nose with Buteyko breathing. Seasonal flu, recurrent allergic reactions, all of this can be treated with Buteyko.
Yes, ma'am. That's all with the questions, ma'am.
Okay.
I would like to invite Dr. Himabindu, ma'am, to extend the vote of thanks.
Good afternoon, everyone. Good afternoon, everyone. Myself, Himabindu, Sub-Coordinator of IAP Human Health Telangana. I feel it's an immense pleasure to say vote of thanks for today's webinar. Firstly, I thank our speaker of today's session, Dr. Ajita ma'am, for giving such a valuable information. It is very useful in this pandemic situation. Thank you, ma'am. Thank you for your time and effort. I express my sincere gratitude to our IAP Human Health Telangana, IAP Human Health National Head, Dr. Ruchivashni ma'am, IAP President, Dr. Sanjeev Keja sir, our South Zonal Head, Dr. Ramya ma'am. Thank you all. I thank our State Coordinator, Dr. Hanna ma'am, for her support and guidance to the team. I thank our Joint Coordinator, Dr. Manjula ma'am, and our Sub-Coordinators, Dr. Monima ma'am, Dr. Himani ma'am, for their cooperation. I thank our IAP technical team for their assistance. Last but not the least, I thank our dear participants for spending their valuable time with us. Thank you, everyone. Thank you.
Thank you, Dr. Ajita and the whole team and IAP technical team for helping us out.
Thank you, ma'am. Thank you, Manjula ma'am. Thank you, Hannah ma'am. Thank you,
Pleasure to
Himabindu
have you here,
ma'am.
ma'am.
Thank you, ma'am.
Pleasure to be here.
Thank you to all the panelists and the viewers. I request everyone once again to kindly subscribe to the YouTube channel, that is YouTube IAP India channel, for more updates on the recent webinars that's about to happen. Thank you to the speaker and thank you to the IAP Telangana Women's Health team. Thank you so much.
Thank you, ma'am.
Thank you. Bye.